Well, that's a very kind introduction, and it's an honor to be here. Um, I want to congratulate Mike Beadle and the colleagues here for doing such a great conference. And this is the second year, and kudos to you guys. This is really important. So it's hard to follow Dr. Sebastiani and Dr. Al-Khoury, but I'll do my best. Those are my disclosures. And I also want to disclose that I don't have a picture of my 5-year-old younger brother like Dr. Al-Khoury had in his presentation. So I'm just gonna make it clinical actually to get to the bottom of it, especially like this is probably the most important thing that primary care need to think of. And indeed, I'm right now in my office and we have implemented a screening strategy of a large network of specialists here in Houston, Texas. And I'm reading the FibroScan that's sitting now in my desk. But let's talk about Anna for a second. And I need to finish this in 10 minutes to keep my promise to Michael. So refer to GI clinic by PCP and for assessment of her liver enzymes. And we'll see if Anna was referred correctly or not. She does have type 2 diabetes, dyslipidemia, for 2 years. Mother had diabetes and father had hypertension. She doesn't exercise, but walks the dog daily, works as HR personnel, and drinks 1 glass of wine every other night. So maybe 3 to 4 drinks a week. Her prior exam, normal except for obesity. She has right upper quadrant discomfort, and she is on metformin. Those are Anna's lab. ALT is 99, elevated AST is 87, normal Billy. Platelet is normal, a little bit on the lower side, normal. A1C is 6.9, and she has dyslipidemia. So I'm going to talk about the society guidelines. I'm going to talk about the diagnosis, and I'm going to summarize. And I'm going to walk you through Anna's journey and if she was referred correctly or not. So everyone talked about this already, but I want to re-emphasize on the spectrum. And these two boxes in particular are the most important ones for us. Why so? Because once you get from simple steatosis or MASL to NASH, once you get NASH and F2 and higher, you increase risk of morbidity and mortality. And those are this box, or what we call them at risk MASH. And eventually you can get to cirrhosis. And this is another box, which is another beast, as they say. And those are the two populations we're targeting in clinical trials right now to have FDA-approved therapies. Tons of data have been already mentioned that NASH and fibrosis, especially at F2 and higher. This data from the NASH CRN said F3 and F4, but there are also tons of other data showing at F2 and higher. So when we talk about non-invasive test, I'm going to tell you where we started. We started here on the top left. We're looking at fibrosis marker. And then people said, well, you have you want me to identify those at NASH and F2 and higher. Can you identify NASH patients and fibrosis? Fibrosis was easy at the beginning when we were just fibrosis stiffness on fibroscans or ultrasound elastographies or MRE detected fibrosis. But the NASH part was a little bit harder because it's usually biopsy diagnosis. So we put models together. I'll show you some of them to predict the NASH and F2 and higher. Anyways, on the left, I can tell you how bad is Anna and if she has NASH and F2 and higher. And along her journey, she needs to be monitored, such as with liver enzymes. And as Dr. Al-Khoury mentioned, eventually, we need to know if this non-invasive test or biomarker can tell me how bad is their case, if they're going to get varices, if they're going to get ascites, A1C of 12, 13, whatever you want to call it, predict future complications from type 2 diabetes, such as retinopathy, proteinuria, and heart disease. So this is the field of NITs. So let me walk you through multiple societies guidelines, and I'm from the US, so I'm a bit biased, but it's in the Canadian, it's in the US, it's in the European. We finally agreed on something altogether. So the American Gastroenterology Association guidelines, look here, it started with type 2 diabetes. So if anything you want to remember today is to screen the type 2 diabetics or 2 metabolic risk factors with a test called the FIB4. And based on the FIB4, you can do either just monitoring or further testing or refer to hepatologist. So the FIB4, and I'll go through it shortly, is a test that consists of multiple parameters that we're going to talk about it. So followed the American Gastroenterology Association. There was the American Association for the Study of Liver Disease Guidelines and the American Association for Clinical Endocrinology. All agree that starting with type 2 diabetes and pre-diabetes, 2 metabolic risk factor, you follow with FIB4. So I'm going to skip why type 2 diabetes for the sake of times, but basically the 2 metabolic risk factors and type 2 diabetes, they increase the risk of cirrhosis and hepatocellular carcinoma. And also they have been shown to be cost effective in multiple studies to screen for this population. Skipping to the FIB4. So this is the FIB4. You go to Google and Google FIB4, and it's age, AST, platelet, and ALT. You just plug in the numbers. And if it's less than 1.3, the patient stays with the primary care. And you can repeat this with the per guidelines every 2 to 3 years. I argue that you can repeat it every year. The test is there. It's just AST, ALT, and platelet and age. If it's between 1.3 and 2.67, they need further testing. And above 2.67, that's a slam dunk referral. Again, if you want to take anything home today, type 2 diabetes and 2 metabolic risk factors, you need a FIB4. So Anna was here. So she was referred correctly because she needs another test in the indeterminate zone. The primary care can do that, the second test, but also it's available in hepatology clinics. So the referral was appropriate because she needs a further testing. Moving on, what we do in the hepatology clinic. We did a transient elastography on this lady, and this is commercially known FibroScan. There are others. On the left, the amount of the fat. On the right, the amount of stiffness or fibrosis. So these numbers, I'm going to explain to you them in a second. But if you move here and we focus on the stiffness, the blue number showed me the amount of fat. The orange number, again, go back here. The orange number showed me amount of the stiffness of fibrosis. And the stiffness is what we focus on, the fibrosis. I told you that's the elephant in the room. So between 8 and 12, she's in the indeterminate zone, and you recommend for further testing here as well. So this is, again, transient elastography. It has these two numbers, the blue cap, steatosis, the liver stiffness, orange, which is the amount of fibrosis. And those are the steatosis numbers, 274, 290, and 302, minor, moderate, and severe. Other numbers, so Anna was here, so she had severe steatosis. If you look at her here, in terms of fibrosis, she was around 9.7 or 9.8. She's between, she's most likely on the F3 range. So if you don't have a transient elastography, the alternative of it is in the guidelines, it's a test called ELF, especially if it's more than 9.8, that also triggers referral. If the patient is a FIB4 indeterminate zone, you do ELF and it's more than 9.8, which predict progression to cirrhosis. Higher level of 11.3 predict decompensation in the future. So back to Anna. So Anna, like I told you, like she fell in that indeterminate zone again with FibroScan. There are other tests such as MR elastography, which is even more accurate than transient elastography. You don't have to do it, but I'm telling you now, we can bypass biopsy in our clinics. And the nice thing about MR elastography that you can couple it with MR fat fraction. And here Anna had MR elastography of 3.3. This is around F2 in the MR elastography. So I confirmed the FibroScan with another test. And this is the MR fat fraction. So Anna here, she got FIB4 followed by transient elastography, and she fell twice in the indeterminate zone. Now I know where is exactly Anna. She's steatosis, moderate to severe, and she has F2. So those are, I direct you to the ASLD guidelines. Those are tests to look at F3s, and those are tests to look at F4s. And usually we do one more than test. Again, for primary care physician, FIB4, and type 2 diabetes or 2 metabolic risk factors, followed by another test if they fall in the indeterminate zone. There are other tests that we, in our clinic, we can look at the SNASH and F2 and higher, and those are usually formulas where we combine the steatosis and stiffness on machines plus liver enzymes, and we can tell where the patient is. So let's put it all together. If the patient has type 2 diabetes or obesity or 2 metabolic risk factors, you do FIB4. If the indeterminate zone, you follow by transient elastography or ELF, transient elastography more than 8 or ELF more 7.7. In our guidelines, it triggers a referral to GI Hep. And we do multiple things. We do NITs and we do these scores that I told you about that determine NASH and F2. We now either start weight loss therapy or put them in clinical trials, and we follow longitudinally along with liver enzymes and see where they are. And in the future, we think we're going to repeat after certain time and see if they're responding to therapies or not. And this is probably going to happen in the near future. So with that, I'm going to stop here. Hopefully quick and short and sweet. Type 2 diabetes, 2 metabolic risk factors or pre-diabetes needs to be screened with a FIB4 less than 1.3, they stay with the primary care physician. More than 1.3, that should trigger you that, hey, I need to do further steps. Thank you for having me.